Welcome. In this session, we are going to discuss the therapeutic principles of uveitis. The goals of therapy of uveitis include prevention of loss of vision while minimizing adverse effects of the various therapeutic regimens employed. And management of uveitis may range from just simple observation to complex medical and surgical interventions. There are certain entities which either dissolve by themselves or do not cause significant visual damage, like mutes, MP, Fuchs uveitis syndrome and mild intermediate uveitis. So simple observation is sufficient in the majority of cases of these entities. Now, one of the most important principles of uveitis therapy is that before instituting immunosuppressive therapy, we have to exclude ocular or systemic infections, including infectious uveitis entities. And we should not hesitate to institute immunosuppressives other than steroids either by ourselves or by a physician to avoid systemic complications of long-term steroid therapy. Adjunct therapy with cycloplegics and ocular hypotensives must be instituted as needed, and coordination with a physician is recommended to take care of the systemic associations of uveitis as well as to monitor for and manage side effects of anti-inflammatory therapy. So medical treatment of uveitis consists of anti-inflammatory therapy, adjuncts and antimicrobial therapy. Among anti-inflammatory options we have corticosteroids and steroid sparing immunomodulatory therapy, which can be of two types, either non-biologics like antimetabolites and biologics like TNF inhibitors. Adjuncts include cycloplegics, mydriatics and hypotensives as we have mentioned, and antimicrobial therapy is required for infectious uveitis processes. So corticosteroids are the standard initial treatment for most non-infectious uveitis entities, and it is still the most effective and most rapidly acting anti-inflammatory in most situations. In addition to non-infectious uveitis, most infectious uveitis processes also require anti-inflammatory therapy, but anti-inflammatory therapy with corticosteroids is instituted only after initiation of optimal antimicrobial therapy in infectious uveitis, and corticosteroids can be given locally or systemically. Steroids must be started at a high dose, so this is also a very important principle of uveitis therapy to rapidly control inflammation and its consequence. So there is a saying, use enough soon enough. So corticosteroid therapy for uveitis should not be initiated at a low dose with the intention of avoiding systemic side effects of steroid therapy and with the plan of escalating the dose as required, because that way we will not be able to rapidly control the inflammation and its consequences. And if oral steroids are used for more than 2 weeks at a stretch for control of the inflammation, the oral steroids should not be stopped suddenly but should be gradually tapered, and the tapering is usually weekly to avoid cortisol deficiency due to suppression of hypothalamic pituitary adrenal axis. Therapy can be discontinued if inflammation subsides and does not flare up during tapering. Alternatively, therapy needs to be continued at a minimum dose at which inflammation does not flare up again, or steroids need to be replaced with immunomodulatory drugs to avoid the side effects of long-term steroid therapy, and dosage needs to be enhanced with topical therapy if ocular surgery is planned, with systemic therapy if ocular or any non-ocular surgery is planned, or in cases of trauma or illness occurring during the period of steroid therapy. Topical corticosteroids are primarily indicated in anterior uveitis. It can also be used to manage the anterior component of panuveitis and is also indicated for uveitic macular edema, and prednisolone is the preferred drug. Difluprednate is an alternative which needs less frequent dosing but has a higher potential to raise intraocular pressure, particularly in children. And fluorometholone and loteprednol are considered ineffective for severe anterior segment intraocular inflammation. So this is also very important to remember. And corticosteroids are initiated as frequently as once every hour. And prednisolone being a suspension, the patient or his relatives should be advised to vigorously shake the bottle before administration, which increases the efficacy of the dose. Local injections, either periocular or intravitreal, of corticosteroids are indicated when there is an inadequate response to topical or systemic therapy. When more posterior effect is required than can be treated topically, when there are compliance issues with either topical or systemic steroid therapy as an alternative to systemic steroids and immunomodulatory therapy, and periocular or intravitreal corticosteroid injections are said to be particularly effective for cystoid macular edema associated with uveitis. We must remember that local injections are a depot form of the drug. That is, we cannot terminate the therapy midway by simply removing the drug injected. So before giving a local injection, either periocular or intravitreal, extra care needs to be taken to rule out a non-infectious etiology and to avoid steroid responsive patients whose IOP increases sharply following steroid administration. And periocular injection should be avoided as a treatment modality for necrotizing scleritis with scleral thinning. Because of the uncertain duration of effect after a single injection, there can be relapse of inflammation before the next injection is administered. And so, the inflammatory damage which occurs between two injections can accumulate if multiple such injections are required. And this cumulative damage in an uveitis patient is said to be a sawtooth decline. Periocular injection can be given either through the transeptal route or the posterior sub-Tenon route, and periocular injections can cause systemic side effects, and the drug usually used is triamcinolone at a dosage of 40 mg, and a single injection of periocular triamcinolone usually works for 3 to 4 weeks. A transeptal injection is given inferolateral to the globe along the orbital floor, and the ophthalmologist pushes the lower temporal eyelid posteriorly with a finger to locate the inferior equator of the globe. So in this picture, this line represents the lid, this the cornea, and this line represents the equator of the globe, which can be palpated by pushing the lower eyelid posteriorly below the globe. And the syringe containing the drug with a 26G needle passes through skin and the orbital septum directly posteriorly. This is important, the direction of the needle along the orbital floor and below the inferior equator of the eye up to the needle hub. The plunger of the syringe is aspirated to check for extravasation of blood, and the drug is then injected. And complications of transeptal injection includes hemorrhage, reverse ptosis of lower eyelid, orbital fat prolapse or atrophy, and globe perforation. But globe perforation is much rare with transeptal injection compared to the posterior sub-Tenon injection. So these two red dots show the location where the needle punctures the lower eyelid in case of right eye and in case of left eye. A sub-Tenon injection is given in the superotemporal quadrant. The upper eyelid is retracted and the patient is asked to look down and nasally. So this is the right eye and the patient is looking down and nasally, and the syringe containing the drug with a 26G needle is placed along the upper temporal sclera with the needle bevel down before starting to puncture the conjunctiva. With a gentle side-to-side movement, the needle is used to penetrate the conjunctiva and the tenon and advanced up to its hub, and the drug is then injected. This side-to-side movement is very important because if the sclera is engaged with the needle, the globe will start to move with this side-to-side movement. And the main complication to worry about during posterior sub-Tenon injection is globe perforation. And other complications which can occur are subconjunctival and retrobulbar hemorrhage and upper lid ptosis. Intravitreal corticosteroids are primarily used to treat uveitic macular edema, and with an intravitreal injection we achieve a higher and a more predictable concentration in the posterior segment compared to periocular injections. In addition to the side effects of the drug, which we would be discussing shortly, the intravitreal process itself has its own set of complications, which are retinal detachment and infectious endophthalmitis. And a single intravitreal injection can work for months to years. And we have several options of steroid preparations for intravitreal injection. 40 mg of triamcinolone, the same drug and dosage which is used for periocular injection, can also be used for intravitreal injection. And following intravitreal triamcinolone injection, 50% have raised intraocular pressure, 25% need treatment for the raised intraocular pressure with ocular hypotensives, and 1% need glaucoma surgery. Following vitrectomy, a single injection of triamcinolone has a shorter duration of action. The POINT trial has showed better efficacy of intravitreal as compared to periocular administration of triamcinolone for uveitic macular edema, but with a higher rate of IOP elevation. We can also inject dexamethasone implant called Ozurdex for treatment of uveitic macular edema, and we must remember that during injection of the Ozurdex implant, the needle must penetrate the sclera in a shelf path, and dexamethasone implant should be avoided with a disrupted posterior capsule because the implant may migrate into the anterior chamber and cause corneal damage. The Huron trial of Ozurdex versus sham injection showed efficacy of dexamethasone implant for 6 months after a single injection. Fluocinolone can also be used as an intravitreal steroid, either as an implant or as an insert, and the MUST trial, the multicenter uveitis steroid treatment trial, compared the fluocinolone implant with systemic steroids in non-infectious uveitis, and the 3-year result of the MUST trial showed similar efficacy, whereas the 7-year result showed that the systemic steroids are better. Systemic corticosteroids are indicated for vision-threatening posterior uveitis and panuveitis, when there is inadequate response to topical steroids in anterior uveitis, when there is an inadequate response to periocular steroids in either anterior or intermediate uveitis, when there is presence of contraindication to topical or periocular steroids, and when associated systemic disease requires treatment. Systemic steroids can be given either orally or as an intravenous injection. Among oral steroids, prednisone is the preferred drug, and this is the same drug which is also preferred for topical application. And the initial dose of oral steroids in uveitis depends on the body weight, and it is 1 to 1.5 mg per kilogram per day, a very important dose to remember, as a single dose in the morning. So the entire daily dose is given as a single dose in the morning. However, even if you follow this formula, the maximum dose recommended is 80 mg per day, and it should not go beyond that. And when there is onset of response or control of the disease, the dosage of oral steroid is tapered, usually weekly, and a maintenance dose of 7.5 mg or less over long term has been shown to be quite safe. So this is a very important dose to remember. And if a higher maintenance dose is required beyond 3 months, immunomodulatory therapy is initiated. Intravenous steroids are indicated in fulminant sight-threatening uveitis, and methylprednisolone is the preferred steroid for intravenous injections. The dosage is 1 gram per day, and this 1 gram is infused over 1 hour. And this dosage is given for 3 to 5 days, followed by oral steroids. Steroids have numerous side effects, and they are important to remember when we are prescribing steroids for uveitis. And the side effects need to be discussed with the patient and his relatives before initiation, and the patient needs to be monitored for the occurrence of these side effects. The ocular side effects include increase in intraocular pressure, development or worsening of cataract, worsening of infectious process, and central serous retinopathy. Systemic side effects include fluid retention and weight gain. This is very common, and all patients need to be made aware of this. Systemic hypertension, hyperglycemia, osteoporosis and avascular necrosis, gastritis or gastroesophageal reflux, insomnia and emotional lability. For gastritis and gastroesophageal reflux disorder, an H2 receptor antagonist or a proton pump inhibitor is also prescribed along with, and a calcium vitamin D supplementation is also recommended to take care of osteoporosis. And it is very important to remember that a combination of oral NSAID and oral steroid should always be avoided because of a high risk of gastritis. Now after steroids, we come to steroid sparing systemic immunomodulatory therapy. And the indications of IMT are vision-threatening uveitis, inadequate response to corticosteroids, side effects and contraindications of steroids are present, or there is a need for long-term steroids. And among IMT, as we have mentioned before, we have non-biologics and biologics. Non-biologics among which we have antimetabolites, alkylating agents and T-cell inhibitors, require weeks to months of administration before they start taking effect. Usually the steroid needs to be continued at a lower dose of 7.5 mg, and less commonly they can be gradually tapered or withdrawn. It is also important to remember that efficacy of non-biologics may continue to improve till 6 to 12 months. Biologics have a more rapid onset of action, and adalimumab, a TNF inhibitor, is the only FDA-approved biologic for uveitis therapy after its efficacy was established in the visual trial. And there are certain uveitis entities which, even though they respond well to steroids early on, it has been found that when IMT is also instituted early on along with the steroids, they have a better long-term prognosis. And these entities include Behçet's disease, serpiginous choroiditis, necrotizing scleritis from systemic autoimmune diseases, Vogt-Koyanagi-Haradas syndrome, sympathetic ophthalmia, and ocular cicatricial pemphigoid. So if we encounter any of these uveitis entities, we need to institute IMT early on in the disease along with steroids for better long-term prognosis. Now there are certain prerequisites before starting IMT. First is there must be absence of infection, absence of pregnancy or breastfeeding. There must be absence of hepatic, renal or hematologic contraindications, and a history of a recent vaccination with a live virus or a live virus vaccination during the course of the IMT are relative contraindications. Co-management by a physician is important to manage the toxicity of IMTs, and informed consent for IMTs is very important, and the patient and his relatives should be willing for repeated investigations to monitor for drug toxicity. And these include hematological, liver function and renal function tests. In hematological tests, along with total counts with differentials, platelet count is also very important. Side effects of IMT, which we will be discussing further when we discuss the individual drugs, are infection, liver, kidney and bone marrow toxicity, increased risk of malignancy, particularly hematological malignancy, and sterility, infusion reactions, and multiple sclerosis and lymphoma. And some recommend prophylaxis for pneumocystis carinii with trimethoprim sulfamethoxazole, and for skin cancers with sunscreens, particularly when alkylating agents are initiated. The SITE trial looked into the cancer-related mortality in non-infectious uveitis patients treated with IMT. However, they did not include alkylating agents in this trial because they were already known to increase cancer-related mortality, and it has been found that there is no increased risk with antimetabolites, which include azathioprine, methotrexate and mycofenolate mofetil, non-significant increased risk with cyclosporine, a T-cell inhibitor, and significant increased risk with TNF inhibitors. And among the antimetabolites, we have azathioprine, methotrexate and mycofenolate mofetil. Azathioprine, being a purine nucleoside analog, inhibits DNA replication, and the dosage is up to 2 mg per kg per day orally. The side effects with azathioprine are slightly higher than with other antimetabolites, and they include GI upset and rare occurrence of hepatic and bone marrow toxicities. So monitoring with blood counts and liver function tests are important. Assay for the enzyme thiopurine S-methyltransferase, which is involved in the metabolism of azathioprine, can be done prior to drug initiation to rule out patients in whom azathioprine cannot be given, or to identify patients in whom azathioprine must be initiated at a lower dosage. Anti-inflammatory effect of methotrexate is by release of extracellular adenosine, and adenosine is an anti-inflammatory molecule. Methotrexate's inhibition of DHFR plays a role in its cancer cell killing activity but not in its anti-inflammatory effect. And it is very important to remember that methotrexate should be given as a weekly dosage, and it can be given either in an oral form or in a parenteral form of 15 to 25 mg once every week in adults, and folate is given concurrently at 1 to 2 mg every day. It has been shown that methotrexate can be given in children, and side effects of methotrexate are GI upset and rare occurrence of hepatic and bone marrow toxicity. So monitoring with blood counts and liver function tests are very important. Mycofenolate mofetil inhibits DNA replication by inhibiting inosine monophosphate dehydrogenase, and mycofenolate takes a shorter time to take full effect in comparison to other antimetabolites and is also much better tolerated. It is administered orally at a dosage of 1000 to 1500 mg per day in 2 divided doses in adults, and side effects include GI upset, rare occurrence of hepatic and bone marrow toxicity. So monitoring with blood counts and liver function tests is also required. T-cell inhibitors, by inhibiting calcineurin, ultimately reduces the production of IL-2 and its receptors, thus reducing CD4 helper T-cell activity. And we have two drugs here, cyclosporine and tacrolimus. Cyclosporine is administered orally and is started at a dosage of 2 mg per kilogram per day and then adjusted according to the serum drug levels, efficacy and toxicity to between 1 to 5 mg per kilogram per day. Side effects of cyclosporine include hypertension and nephrotoxicity, and these are the most common and most serious toxicity of cyclosporine. And so cyclosporine therapy requires monitoring of blood pressure, serum creatinine and blood counts, and a 30% rise in serum creatinine indicates need for either dosage adjustment or drug withdrawal. Other side effects of cyclosporine include gingival hyperplasia, hypertrichosis, gastrointestinal intolerance and paresthesias. Tacrolimus has been found to be equally effective as cyclosporine, with a lower risk of nephrotoxicity but with its own risks of neurotoxicity, hepatitis and diabetes. Alkylating agents alkylates and cross-links DNA bases, thus inhibiting both RNA production and DNA replication, and they are indicated only in severe, vision-threatening and life-threatening situations. In necrotizing scleritis, alkylating agents are considered as first-line drug, and alkylating agents may also be required in recalcitrant Behçet's disease, VKH and sympathetic ophthalmia. However, alkylating agents are associated with the dangerous risk of malignancy as well as sterility, so they must be used with caution and only if other drugs are ineffective. And among all anti-inflammatory therapies, alkylating agents have the highest chance of inducing long-term drug-free remission. Among alkylating agents, we have cyclophosphamide and chlorambucil. Cyclophosphamide can be administered orally or intravenously, and along with myelosuppression, hemorrhagic cystitis is an important side effect of cyclophosphamide, so blood counts and urine analysis should be done repeatedly. Chlorambucil needs to be administered orally, and it has its risks of myelosuppression and hepatotoxicity. Coming to biologics, they target specific inflammatory mediators, particularly cytokines, and compared to antimetabolites and T-cell inhibitors, they are more expensive with a higher risk of infection and malignancies, and they are indicated in specific uveitis entities and when there is a poor response to non-biologic IMTs. TNF inhibitors are the biologics primarily indicated for uveitis, and TNF inhibitors by expert consensus are now regarded as first-line therapy for Behçet's disease. TNF inhibitors are also indicated for recalcitrant juvenile idiopathic arthritis and spondyloarthropathies, and risks of TNF inhibitors include multiple sclerosis, malignancies like lymphoma and secondary infections. Congestive heart failure is an important contraindication to TNF inhibitor therapy, and other contraindications include latent tuberculosis and recent administration of live vaccines. And adalimumab is the first FDA-approved systemic therapy for non-infectious uveitis, and its efficacy was demonstrated in visual trial. Adalimumab, in contrast to Infliximab, is a fully human monoclonal IgG1 antibody to TNF with a lesser risk of anti-drug antibody production, and it is injected subcutaneously and can be self-administered like insulin, and the initial dose is 80 mg followed by 40 mg every 2 weeks. Infliximab is a mouse and human chimeric IgG1 antibody to TNF, and it is administered intravenously. Because it's a chimeric antibody, it has a greater risk of anti-drug antibody production, resulting in treatment failure and drug-induced lupus. Other biologics which have been reported in the literature for treatment of uveitis include rituximab, interferon alpha, and abatacept. NSAIDs are ineffective in most intraocular inflammation, but oral NSAIDs are indicated in mild to moderate non-necrotizing anterior scleritis. But oral NSAIDs, as we have mentioned, must never be combined with oral steroids because simultaneous therapy has a significant risk of gastric ulceration. Topical NSAIDs can be administered in mild episcleritis and they are indicated for macular edema. Intravenous immunoglobulin is indicated when IMTs are not able to control the disease process. And with such a large range of anti-inflammatory options, how do we choose one? And the protocol is we start with an oral steroid and we also start with an antimetabolite for uveitis entities known to benefit long term from early institution of IMT. Pulse steroids can be preferred for fulminant onset of vision threatening disease. If the steroids are not effective or are required at a dose of more than 7.5 mg per day for more than 3 months, then IMT is initiated. And the sequence of choice of IMT is usually as follows. First, antimetabolites are started. If antimetabolites are found to be not adequate, then either TNF inhibitors are started, or alternatively another antimetabolite or a T-cell inhibitor can be tried before TNF inhibitors are started. Alkylating agents, because of its significant serious risk of malignancy, is indicated only if a combination of antimetabolites, T-cell inhibitors and TNF inhibitors produce an inadequate response. However, alkylating agents are a drug of choice for necrotizing scleritis. Now, in this protocol, if a drug has a suboptimal response, it is usually retained in the regimen while another drug is added. But if the drug has minimal or no response, it is withdrawn from the therapeutic regimen. However, each drug should be given adequate time to demonstrate its response before its efficacy is evaluated. Because as we have seen, antimetabolites may take weeks to months to start taking effect. Among drugs which should be given in addition to anti-inflammatory, we have mydriatic cycloplegics which relieve pain and photophobia from ciliary spasm, break already existing posterior synechiae or prevent new posterior synechiae from forming, and by pushing the lens iris diaphragm posteriorly, they may also prevent peripheral anterior synechiae formation, and they also allow fundus examination. What is important is shorter acting agents keep the iris mobile, thus preventing synechiae formation, but require multiple instillation per day for adequate pain control. And longer acting agents require once daily administration for adequate pain control but allow synechiae formation in a dilated state of the pupil. Oral carbonic anhydrase inhibitors have a role in diffuse macular edema from RPE leakage, but macular edema from vascular leakage do not respond to oral carbonic anhydrase inhibitors. Infectious uveitis entities require antimicrobial therapy, and they will be mentioned when we discuss the individual infectious uveitis. And surgical therapy for uveitis is usually required for managing complications, and they will be discussed in the session on complications of uveitis. Thank you for listening.